Hello, this is John Kanalopoulos from our center here in Athens, Greece, the Laservision Ambulatory Surgery Center. This is a quite complicated and past history patient. This is a young lady who unfortunately had a serious cornea ulcer. She had a cornea transplant in Vienna by Dr. Hruby's team, if not himself, in 1980. So this is 44 years ago. And subsequently in 2000, she had from one of Dr. Hruby's students here in Greece, an ICL placed. We can see the iridotomy at the 10 o'clock position. Now she has cataract. She has a failed graft, and we can see that we would like her endothelial cell count on the other eye. Unfortunately, her cell count is gone. The graft is edematous, and the calculated cell number is under 1,000, under 800 actually. So this is on the day of our procedure. We're marking the 6 o'clock on the slit lamp that we'll use later. This cornea, although it's 44 years later, is quite steeper than what I'm used to in my practice. My usual keratometry post cornea transplant is 42 to 43. And these keratometries do require toric IOL, although we will plan for a dissect procedure or a regraft. And this is evidence that the graft has failed after all these years. But we nevertheless, since there's a lot of regular astigmatism, will try, in case she undergoes dissect, to place the incisions as much as possible on the 30, 100, and on the 36-degree axis. This is the ICL, which is an amazing lens, and it's not a coincidence that after all these years, we went through many circles on phakic IOLs, and we're back to the ICL being the probably only current option. So we're carefully, because we don't want to damage any more the graft endothelial surface, we're gently going with a Kugelin and a Sinski hook to unravel the haptics of the ICL. We can see after all these years how atraumatic the placement of the lens was for the eye. There's no pigment on the lens. We can take a look at it. This is ICL placed 24 years ago. The challenging thing here is that the optics are much worse in the procedure than you're actually seeing here, being captured with a video. So the capture X is very challenging. I decided against using blue to enhance my capture X's because we know it's slightly endothelial toxic. So I will go very carefully to do a careful continuous curvilinear capture X's, and kudos to Thomas Neuhan, who described this. I remember I was a resident at the time. I think it was 93, 94. Amazed of watching his videos introducing the CCC, and we thank him for that. And we completed the capture X's. I apologize, part of the image is outside our field, but here I'm going to use a little bit more viscoat to tighten the anterior capsule, help me visualize a little bit better, and unfold the capsule that I have already torn with my Utrata forceps. And I'll grasp again where I left behind, and I'll continue the capsule X's. Hopefully I will move the scope more towards the area that we want to see. But again, the key point here is that the optics during the procedure are very poor. That's why I'm on minimal illumination for my microscope standards, in order to enhance the red reflex and help me lead the cutting edge or the tearing edge more precisely of the continuous capture X's. So we're focusing on this because this was apparently the most challenging part of the procedure. Following that, we have a cataract procedure that is relatively straightforward, although still the poor visibility and visualization is challenging. We're going to go in with divide and conquer with our signature device. There's a lot of room. Obviously, this is a very long eye. The interferometry is 29 millimeters, and again, we saw keratometry of 50 to 52 an average. So this is a very deep eye. We could see floppy iris as well. I don't know how much part of that is the fact that it was an ICL in the eye for all these years. I'm using methocellulose. We will remove now the cortex. Again, challenging due to the pupillary constriction, I use the little of epi, diluted epi to attain some extra dilatation, which is very helpful. This is our lens. It's a +2 lens, although our biometry recommended a -2 lens, so I'm preempting a possible dissect procedure or a future regraft in which, in my standards, the keratometry would be much flatter than the average of 50 that we have here. I use a special technique with the MA lens, the 3-piece Alcon lens, which is our go-to lens for under power of 6, to place it dry on the folder so it doesn't flip. And I see I'm using my toothless forceps to push the lens on the backside and help it fold upwards. Otherwise, these lenses are so thin they can fold into an S, and they'll be very difficult to grasp with our insertion forceps. I'm hydrating now the lens on both sides with BSS so it unfolds after I'm placing it here, after it's been grasped with the insertion forceps. I'm using my Sinski hook on the left-hand side. Very privileged to have met Bob Sinski back in his day and his contribution to microincision phaco surgery and the invariable and unparalleled tool for basically all the procedures I perform, both lens-based and cornea-based. And here we have to place, as you can see, 3 master sutures, attain a watertight wound, and a very nice procedure. So a lot of history here. The ICL in perfect condition 24 years later. Thanks so much for your attention. This is John Canelopoulos from our center here in Athens, Greece, signing out.